you, Mr. Chairman. الحقيقة I would like to welcome all our distinguished guests to the 43rd annual conference of the Egyptian Society of Nephrology and Transplantation, especially our guests from outside Egypt, from our Arab countries and Europe and the States. As Professor Professor Azzat mentioned that after a long time of almost no effective treatment for patients suffering from polycystic kidney disease, and we all know that it comes in families. There are many families who have this kind of disease, and what we used to do is just kind of supportive treatment, trying to reduce the progression rate, reduce the rate of complications, but definitely our patients, most of them usually reach the end stage. So this medication that we are going to talk today, thanks to Hekma for bringing it to Egypt with rather affordable price, because it was already in the market for almost 5 years or 6 years. I had the pleasure to attend the launch of this medication in the United States when he took the FDA approval, but it was damn expensive by that time, and actually that was far beyond our capabilities. But now, after bringing it now, the price is rather affordable. So what's autosomal dominant polycystic kidney disease? It is what we previously used to call adult polycystic kidney disease. It is the most common genetic disorder leading to renal failure worldwide. It's a multi-system and progressive inherited disorder characterized by formation of renal cysts, kidney enlargement, and involvement of extrarenal organs such as liver, pancreas, spleen, heart, arachnoid membranes, etc., and of course the kidney. The underlying cause of autosomal dominant polycystic kidney disease is a mutation in one of two genes, the PKD1 or PKD2. These genes code for the proteins called polycystin-1, the PC1, and polycystin-2, the PC2, respectively. While cysts can sometimes be detected in children or even at birth time, and in this case, it becomes more aggressive, and the fate of the patient is much worse than when it presents within the usual presentation around the age of 30s and mid 30s and early 40s. Sometimes it presents somewhere around 18 years old and above. So that's the usual age for presentation. As I mentioned, it is a genetically disordered, primarily caused by mutation PKD1 and PKD2. The major or predominant mutation is the PKD1, almost 80 to 85% of patients, PKD2 around 15%, and very rare what they call GANAB or GANAB mutations, about 1%. The PKD1 and PKD2 mutations share similar clinical features but differ in severity. PKD2 patients generally experience milder symptoms with later onset hypertension and less progressive to end-stage kidney disease than PKD1. The overall autosomal dominant polycystic kidney disease progression involves systemic vascular resistance, sodium retention, renal fibrosis, and increasing cyst burden, all continuing to the eventual development of end-stage kidney disease. As I mentioned, and early detection management is very important to try to alleviate this condition. So what are the signs and symptoms? Usually, the main symptom that the patient presents with is pain. And this is the most commonly presenting symptom, and usually almost 100% of patients present with pain. The source of pain may be due to cyst growth, bleeding, especially in the cyst, infection within the cyst, and kidney stones, which increases in this case with autosomal dominant polycystic kidney disease, and very rarely cancer also. The pathogenesis and complications, usually 95% is inherited autosomal dominant mutations, and 5% they come as spontaneous mutations. They are not inherited. PKD1 mutations, as I mentioned, usually around 80%, PKD2 15%, and rarely the PKD3 mutation, which is very rare. PKD1 mutation have more severe prognosis than 2, as I mentioned. In adults, the same pathophysiology occurs in epithelial tissue throughout the body. It may occur in many organs like the liver, almost 90% of cases, spleen, pancreas, and thyroid. In seminal vesicles leads to infertility, in GIT leading to herniation and diverticuli, in the brain leading to the very famous Berry's aneurysms, around 10% of cases, in the heart involving the valves, causing valve prolapse and regurgitation, in the kidney, of course, all segments of the nephron can be affected by cyst development. Sacs of flattened epithelium filled with proteinaceous fluid, replacing normal parenchyma with dysfunctional tissue, leading to a huge abdominal mass due to enlarged kidneys and multiple renal cysts. So when this happens, you may have affection of the collecting ducts, leading to inability to concentrate urine, which leads to low urine osmolality, and the urine osmolality becomes less than 500 millimole per kilogram, low urine specific gravity less than 10, or dysfunctional proximal tubules, leading to increased acidity of renal tubules, which will eventually lead to nephrolithiasis. Urine accumulates within the cyst, leading to precipitation of calcium oxalate stones within cysts, also leading to nephrolithiasis, and bacteria accumulation in the static urine, leading to pyelonephritis, and cyst growth, which activates the nociceptors, leading to the flank pain, or also it could be due to the hematuria within the cyst, which also will lead to activation of nociceptors, leading to flank pain. Cysts compress renal vasculature, causing hypertension, and cyst hemorrhage also, and eventually damaged tubule leak protein into filtrate, leading to proteinuria. So what's the epidemiology, especially in globally and in the MENA region, the Middle East, North Africa? It's the disease prevalence is difficult to estimate due to the lack of practical screening. A positive family history raises the likelihood. About 50% of cases comes with positive family history. Genetic studies suggest prevalence of around 1 in 400 to 1 in 1,000, while population-based studies report lower prevalence, حوالي 25 to 68 per 100,000, and the global burden is حوالي 12.5 million, 12.5 million patients. The prevalence is higher in non-Hispanics, اللي هم الCaucasians, the white, the Europeans. It's almost 63 in 100,000. Africans and Black Americans, around 73% in 100,000. In Hispanics, almost 39%, or 40%, let's say, and Asians around 50%, in 50, sorry, per 100,000. It is a worldwide condition, as I mentioned, 1 in 1,000. Up to 75% of patients develop end-stage kidney disease by the age of 70, which accounts around 10% of all population on the reaching end stage. And the global incidence is around 12.5 million, with a rate of 7.8 to 6 per million in Europe and 5.6 to 4 per million in Japan. And as I mentioned, in Hispanics, it's even less, around 3.9 per million. The burden of the disease is due to progression associated with burden. Some have some symptoms of anxiety symptoms, such as kidney pain, gross hematuria, and urinary tract infection, as well as systemic complications as hypertension. In advanced diseases, patients experience severe chronic kidney disease and ultimately kidney failure. The age of symptoms onset differ among individuals, given the autosomal dominant polycystic kidney disease, a highly variable rate of progression. Individuals face multi-dimensional and often lifelong disease impact. The knowledge, ودي حاجة مهمة قوي, of having this disease have very deleterious psychological effect on those who have this disease, because the fear and the sense of guilt that they might transfer this to their children. And many of the patients comes to you not worried about themselves as much as they are worried about whether their kids will have the disease or not. A potential financial impact, of course, including decreased ability to work, negative effects of a diagnosis on insurability, and the costs of medical care. Again, with the burden of the disease, the common complication is end stage, reaching 20 to 50% within 2 years. The patient, the mortality increases to almost 50%. Coronary heart disease, peripheral vascular disease, and hypertension. And of course, maintenance dialysis with all the dialysis-related complications. Among the subset of patients above 65 years old, the age-adjusted mortality in the non-end stage kidney disease CKD cohort is highest in the Black patient, around 82.7 deaths in every 1,000 patient per year. However, age-adjusted mortality in the end-stage renal disease cohort was highest for white patients, around 136 deaths per 1,000 patients per year. What is the non-pharmacological management that we used to do for our patients? First of all, protein restriction, sodium intake restriction, absolute sodium intake restriction, aerobic exercise is important, blood pressure control as well, especially with ACE or ARBs, caloric restriction and weight management, and the most important thing is excessive hydration, profuse hydration. Up to 7 to 10 liters per day, the patient should be instructed to drink per day. The pharmacological management of autosomal dominant polycystic disease that we used to do is alleviate flank pain, exclude causes like infection, stones, herpes zoster, etc. Cystic hemorrhage, usually self-limiting, managed with best rest, analgesics, and increased fluid intake. وطبعا, unfortunately, some go for some surgical maneuvers, which is totally not right. Cysts and UTI infection require immediate treatment to prevent retrograde seeding. Preferred antibiotics is trimethoprim, sulfamethoxazone, ertapenem, fluoroquine, and clindamycin, etc. And nephrolithiasis, it's common, as I mentioned, especially oxalates. And uric acid stones. Treatment includes urine alkalinization by potassium citrate and increased fluid intake. Hypertension management, as I mentioned, angiotensin inhibitors and angiotensin receptor agonists. These are the most commonly used. But yet, we still have unmet needs in the current autosomal dominant polycystic kidney disease treatment, which is the FDA acknowledges that drugs with large treatment effects may be approved without restrictions due to the unmet need for therapies in kidney failure, including those for lower risk patients. Research is needed to identify new targets and optimal timing for early stage interventions before significant kidney damage occurs. And key challenges include biomarkers to measure and predict the disease progression from childhood and distinguishing slow from rapid progression, and early treatment should be prioritized, but substitutes for end-stage, of estimated GFR and other progression biomarkers are still lacking. We don't have that sensitive marker that tell us when to start. Hence, the introduction of tolvaptan for the treatment of this serious condition. What is tolvaptan? It's the only FDA-approved treatment for autosomal dominant polycystic kidney disease, risk of progression, slow disease by blocking vasopressin V2 receptors, reducing cyclic AMP and cyst growth, and recommended for patients with a yearly GFR decline of more than 3 milliliter per minute due to autosomal dominant polycystic kidney disease based on at least 5 measures, يعني 5 years تقعد تmeasure for over 4 years, تقعد تmeasure تبقى عندك 5 measures over 4 years, excluding other causes like vascular disease or diabetes. If there is lack of evidence for rapid disease, مش كل عيان هيجي لك انت already you have him for 4 years and you are measuring the cyst progression or the GFR decline. If you don't have this record, so progression based on evidence can be based on diagnostic, imaging, and or genetic testing, like kidney length more than 16.5 by ultrasonography or total kidney volume above 750 milliliter.
Dear doctor, your time is up.
كان 3-4 دقايق ماشي. يدونا ممكن فين اوكي ثانك يو. وجيناتيك تيستينج فور بي كي دي 1 بي كي دي 2. انا همشي بسرعه بقى عشان الوقت. بسرعه الميكانيزم. الفازوبريسين binds to principal cell receptors activating the aquaporine 2 with increased free water reabsorption and urine osmolarity. Then tolvaptan, a selective V2 receptor antagonist, blocks vasopressin on renal collecting duct cells, inhibiting aquaporine 2 protein transport and reducing free water reabsorption. And this results in increased water excretion without significantly affecting sodium or potassium. وبالتالي هو is aquaretic rather than traditional diuretic. طيب الابديت of the efficacy. total kidney volume increase is a surrogate marker زي ما قلنا. التيمبو ستادي قالت انه بيقلل الانكريز في السايز 1 مليلتر بير مينت بير يير من 3.7 ل 2.7 في early stage over 3 years. Torvaptan affects the size is comparable to renin-angiotensin system. A Tempo 4 open label extension study showed persistent over an additional 2 years after stoppage of the disease. Reprise trial provided strong evidence for tolvaptan in later stages كمان. يعني الستيجز لما يكون جي اف ار 25 او من 65 ل 25 مليلتر per minute for those between 18 and 15 و 25 ل 45 for those above 55. Tolvaptan slowed the growth, the estimated GFR decline by 1.27 milliliter per minute. يعني the studies proved this. Advantages of tolvaptan over other treatment. It reduces increases أولا the life expectancy by 6.5 years. And increase the duration to end stage by 6.5 years and increase the life expectancy by 2.5 years compared to other treatment. Stratification tolvaptan is most beneficial for those over 35
Dear
with
doctor,
hypertension.
your time is up.
يعني هو ادونا دقيقتين. انت عندك جلاسك هيخش دلوقتي؟ ماشي واحد لو عايزين. اوكي خلاص يعني عشان الوقت وطبعا الديلي اللي حصل فبنشكركم ويعني ان شاء الله يعني tolvaptan الكي التيك هوم مسج. tolvaptan is now available in Egypt. We can use it. الدوز فيه بينزل 15 ملغ 30 ملغ 45 and 60 ملغ. The optimum dose is to give in the morning 60 or 90 mg and after 8 hours, not in the evening, after 8 hours 30 mg. You build up the dose. دايما الدose in the morning, twice the afternoon dose. If you reach 90 and 30, the 120 mg, this is the best. If you cannot reach it, يعني you can reach as much as the patient can tolerate the dose as much as possible. ويعني وده ال take home message. Thank you.